Hello everyone. Today I'll be talking to you regarding mitral regurgitation as well as mitral valve prolapse. Mitral regurgitation. So before I discuss the topic, a brief review of the anatomy of the mitral valve. We know this is the left ventricle and this is the papillary muscle. The two papillary muscles, and they are the chordae tendineae, and they are attached to the valve mitral leaflets. And this is the annulus, is the structure to which the mitral valve leaflet are attached like this. The two leaflets attach. Just to give example, in your door where you are sitting in the room, we have the two part of the door and they are attached to this to the main board. Annulus is like this and doors are the cusp. Okay, right, sir. With this background, little bit of what changes occur in mitral regurgitation. We all know that in mitral regurgitation there is a gap in the mitral valve. They don't close properly, the two leaflet. That's why the blood can regurgitate from LA to left ventricle to left atrium. Same thing, let me show you. This is the normal valve and this is the mitral regurgitation. Now you can see there are two cusps. One cusp is this and the other cusp is this, and there's a very well gap is there, and from this gap now you can see much better in this picture. Gap is there. This is clearly visible everywhere, so you can get a gap like this. This is the purpose of telling you about mitral regurgitation. With this background, now we talk about causes of mitral regurgitation. One thing is that we have understood this is the heart, mitral valve, and blood will be leaking from LV to LA is the most simplified version, but I can present to you, which I show you in the previous slides about in the picture also. Now let us see what are the cause of chronic MR. Point to be noted, this can be mitral regurgitation MR can be chronic or acute. Let us see what are the cause of chronic. Functional means left ventricle dilatation. This is classical example of this is dilated cardiomyopathy. A very commonly asked question is this. And how and what it happened, I'm going to discuss in the next slide. Annular calcification. Now again, you go back to the anatomy, what we learned just now, that I show you, and this is the annulus. If this get calcified, it become rigid, that the mitral, that leaflet, they lose the mobility of movement. And now these two cusps will not close properly. They will not close in opposition, so that leakage will be there. The problem lies in the annulus calcification. There the idea was to tell you to revise the anatomy of the mitral valve. Okay. Again, so we learned, of course, rheumatic fever and rheumatic heart disease, very common in the developing country and underdeveloped countries. Mitral valve prolapse, in fact, it's the most common cause of mitral regurgitation, especially in the European and in USA, in UK and USA. This is the most common cause is MVP. Connective tissue disorder like Ehlers-Danlos syndrome and Marfan. This is the most important. In Marfan syndrome, in Marfan syndrome, MVP is very common. And we know in mitral valve prolapse, mitral regurgitation occurs. It can be congenital. Point to be noted that mitral stenosis is very rarely congenital, but mitral MR can be congenital. They're all cause of chronic mitral regurgitation. Now I mentioned to you regarding functional MR. Okay, now let's talk more in detail about functional MR. Now it occurs not due to any pathology of the valve. Valves are quite normal. There is no problem in the valves at all. It's simply either LA dilates or LV dilates. Either the left atria or the left ventricle dilate. When they will dilate, so this causes mitral valve annulus to dilate also. So definitely they cause stretching of the annulus, and the annulus gets stretched. Remember, it's a viable normal annulus. It gets stretched up. So definitely, let's say this is the normal annulus, this is the valve, this is the valve. Now annulus get dilated, gets stretched up. Valve remain like this only. So now a gap is there, and that is going to create the mitral regurgitation. Normally these cusps, they are like this, they are closed. Normally these cusps are like this. Now we are getting a gap. But this is due to either stretching of the left atrium, or it could be due to stretching of the left ventricle. But left ventricle stretching is much more common cause as compared to left atrial stretching. Okay. So now, like in dilated cardiomyopathy, there is this, the heart. Okay. And I'm just showing the only left ventricle. This is the annulus. Now if it get dilated, this also get dilated, and that lead to MR. Now in DCM, primarily it is systolic dysfunction. There is left heart failure. Of course, there is right heart failure also, but at the moment I'll talk about left heart failure. Due to left heart failure, the left ventricle get dilated and the annulus get dilated. But why I'm spending so much of time in explaining to you? Now when I'll be treating this case of mitral regurgitation, the treatment is totally different, but I'm going to discuss a little later on. Here I'll be treating dilated cardiomyopathy. So I'll be treating, once I treat, and we know there is systolic dysfunction in DCM. So my aim will be treat the basic cause. Once we treat the basic cause, automatically the ventricle size will come to normal, and automatically the murmur will disappear and MR will disappear. Okay. So due to LV dilatation, the treatment would be directed at the reversal of the heart failure. So what is the important keyword to be remembered in this particular slide? In functional MR, this is due to dilatation of LA or LV. That lead to annulus dilates, and treatment will be treat the basic cause of heart failure. So there are only three keywords to be remembered: LA, LV dilate, annulus dilate, and treat the basic cause. No need to touch the valves at all. Okay, with this background, now we talk about acute MR. Acute MR, that means it develops suddenly. It develops suddenly. And in the chronic, it was slowly development. Definitely the word itself says. Now before I go for acute or chronic, whenever in a question in the exam, they are talking about MR, it is understood that they are talking about chronic MR. Chronic, it is understood. But and if the examiner has to ask you about acute MR, they will ask the word acute mitral regurgitation. So no confusion about MR also. So acute MR occurs in conditions like endocarditis, rupture chordae tendineae, papillary muscle dysfunction, or failure of the prosthetic valve. Okay. Well, if I have to show you again the diagram, so the diagram goes like this. If he says acute, so in the acute, what he discussed, what he told was, number one, anything papillary muscle dysfunction, this is the one. And this typically occurs in myocardial infarction. Chordae tendineae, this structure, and this typically occurs in endocarditis. Okay, endocarditis is the second one, chordae tendineae rupture. and it may even occur in endocarditis here also. So either chorditendony involved, or it may be there may be involvement of the endocardial lining anywhere. They all lead to acute mitral regurgitation. Okay, right, sir. And last but not least, we have a prosthetic valve. Prosthetic valve we can replace in mitral stenosis or maybe mitral regurgitation. If that has a sudden malfunctioning, that can again lead to acute MR. As such, the original valve, they usually do not cause acute MR. Only prosthetic valve, where the valve has already been replaced by any artificial valve, that can cause acute MR. So with this background, we move further. So we learned about acute causes. So now let's talk about pathophysiology of acute MR. What happened? Why I mentioned the two causes separately, because they both have different pathophysiology. So let's learn the pathophysiology of the acute MR. This is the heart. This is the mitral valve. This is the pulmonary vein. Now acute MR, suddenly blood start flowing from left ventricle to left atria. Leakage is there. Mitral regurgitation acute. This blood comes to left atrium. But this, and remember, left atrium, rather both the atria are thin walled chamber. Thin wall chamber. They cannot accommodate much blood. They have a limited space. Okay. Well, if I have to give you day-to-day example, there is one gentleman who stays in a small house having 2 rooms, where he, his wives and 2 children are staying, 2-room flat. Suddenly 5 people come as a guest. Now 5 people, already 4 people are there, 2 husband, wife and 2 children in 2 rooms. These 5 people cannot be accommodated here. Why? The space is less. Same thing. When the blood comes to LA, suddenly huge amount of blood comes. This cannot accommodate the blood. So now this blood will straightway go to the pulmonary vein. One more thing, in the pulmonary vein, unfortunately, pulmonary vein, they don't have valve, no valves. I hope you are aware that in the pulmonary vein and the brain of the veins, they don't have valves. Valves are in the leg, okay, or the arm, not in the pulmonary veins. So no valves, straightway this blood will enter the capillaries. Pulmonary capillary. So immediately pulmonary capillary will get congested. That lead to acute pulmonary edema. If not, at least congestion will happen. The patient will develop dyspnea. Sudden onset of dyspnea will be there. Understood? So this is all about in acute. Right? Now let's talk about what happened in chronic valvular disease. Same story. Heart and now I'm talking about chronic. In systole, blood come to the LA, but it is a chronic, slowly developing chronic. So in due course of time, this LA will start enlarging. It is start enlarging. With the result, it has got more space to accommodate blood. Okay, so blood is coming and accommodating, so LA will enlarge. Why? Again repeating second time. Now it is like a balloon. Blood is coming slowly, slowly, slowly. It can do with the due course of time. It is expanding. Okay, but suddenly blood comes. It cannot expand. Agreed. Well, it is enlarging. So one main difference between acute and chronic is LA enlarge. Okay, LA will enlarge. And what else will happen? This is the aorta. So during systole, now this point you have to note, think, listen to me very carefully and understand. So during systole, in chronic cases in particularly, some blood goes to the LA and some blood goes to aorta. Although normally the whole blood, whatever has to go out of the LV should go to aorta. But here partly going to aorta and partly going to LA. Now both of these will have different impact, and the impact will be like this. As the amount of blood going to aorta is reduced, definitely, so this will lead to, so that means the amount of blood going to the peripheral tissue is reduced. Blood in the peripheral tissues will be reduced. So with the result, patient will have a easy fatigability. Patient will have a easy fatigability. Patient get fatigued very fast because the amount of blood coming to the aorta is reduced, and thereby peripheral tissue is getting less blood. Second thing, in due course of time, as the blood is coming to LA, it is accommodating, but in due course of time, in the advanced stages, blood will start entering the pulmonary veins. It will lead to pulmonary venous hypertension. Same thing, pulmonary capillary hypertension, pulmonary arterial hypertension. Sequence will follow. But in due course of time, not suddenly, particularly pulmonary capillary congestion, this will be happening in the late stage. So dyspnea will be happen, but it is a late feature. This is in contrast to mitral stenosis, where dyspnea was the early feature. Now one more thing, this is the most important line. So what I told you just now, in this the LA size has increased. Agreed. One more thing, LA size, not only LA size is increased as the more and more blood coming to LA, even LA pressure also increases. LA pressure also increases. Now you are going to ask me a question. Same thing happened in mitral stenosis also. In mitral stenosis also, LA pressure increases, LA size increases. Both. Then what is the difference between the two? And now come the gold medal question is this. Yes, LA size increases in mitral stenosis. Mitral stenosis again a very slow process, never occurs overnight. Chronic MR, slow process, never occur overnight. But what is this? So, well friend, in mitral stenosis, LA pressure increases in diastole. And in MR, this happen in mitral stenosis. But in MR, this occur in systole. MR. This is the major difference in the LA pressure. LA pressure in during MS and MR. Let me explain to you. This is the mitral valve, mitral stenosis is there. And during diastole, this will try to dilate, and now this LA has to put the blood against the stenotic valve. Stenotic valve, it has to put against the pressure. So in the LA pressure will increase in diastole, in mitral stenosis, in diastole. But in contrast, in mitral regurgitation, this is the aorta. And when systole occur, blood come here and blood comes here also. So large amount of blood has come to LA in systole. This causes increase LA pressure in systole. They are the basic about the pathophysiology of AR and MR and acute and chronic MR. Okay, so you are clear about this thing. Now, what I told you, same thing I'm going to tell you in a very nice diagram. Well, we have a pressure and this is the volume. Okay, curve 1, you can see volume is increasing. Of course, no need to say, I'm talking about left atria, no need to say. Volume is increasing, but pressure is slowly increasing. But in case of acute, suddenly volume has increased, the pressure has increased much faster. Look, volume and see the pressure. So this volume is this, but in the same time, the pressure is very, very high. So now you can have a nice correlation that in acute, sudden rise of pressure occur and here it is, occurs very slowly. What I can say in other way around also. The other way around is in case of acute MR, this much pressure has come with this much volume. And in chronic, this much pressure has come with this much volume. This is the volume and this is the volume. I hope you got the idea of volume pressure relationship. Okay. Well, right. So this is curve 1, chronic, and curve 2 is acute mitral regurgitation. I hope you have written it. Yeah. Now let's talk more detail. Left heart catheterization we do to do the study. So now we have learned that there is excessive rise of LA systolic pressure, a finding that is characteristic for mitral regurgitation, and this I explained to you beautifully by the diagram and with the curve also. Now that we know. So in a normal, now let us see what happened in a normal individual. In a normal individual, when the pressure comes, LA pressure increases to about 10 millimeter of mercury. Okay, 10 millimeter of mercury. Why? Let's learn the basic concept. And that also during systole, and that is due to passive filling of LA. I want each one of you to note this point very carefully. First point, in a normal individual I am talking about. I am not talking about MR. In a normal person, LA pressure increased to up to 10 millimeter of mercury. This is occurs in systole and this is due to passive atrial filling. I'll explain to you more in detail about it. What he is saying, in a normal person also, the LA pressure can go high up to 10 millimeter of mercury. We all know very well. This is the LA, and we know the normal pressure of LA is about 10 to 14 millimeter of mercury. This is the range. Well, this LA is getting blood from where? It's very simple. It is getting blood from the pulmonary vein. Even the school boy knows who reads the biology. Yeah. So now when systole is occurring, this ventricle is contracting. Yes, we know very well. Blood is getting pushed into the aorta. We know very well. But during that time, when the ventricle are having systole, the atria is having diastole. Atria is having diastole, atria is dilating and it is getting blood from the passive blood it is getting from pulmonary vein. So as more and more blood come in diastole, so that's why the pressure may go in a LA. In a normal heart, it may go up to 8, 10, 12, and for easy calculation, I take 10. So now we understood what the meaning of passive return to blood in LA during diastole in atria. So this we can see in cath. Now, suppose now during catheterization we take a tracing of the pressure changes. Well, this is the 4 millimeter mercury during systole. During systole, systole means a ventricle systole. But just to remind you, when the ventricle are systole, atria are dilating. So we will be getting passive return of the blood, and that we record as V wave. V wave in catheterization in left atrial pressure recording. So we are getting V wave in the left atrial pressure in during ventricle systole or atrial diastole. The thing remains the same. Okay, so we know, today most of you are listening for the first time that there is a V wave in left atria also, although we have been reading V wave in JVP, but we have a V wave in LA also. With this background, we move further. Now, what happened in mitral regurgitation? Now, you are all very, very intelligent. So, we are getting the pressure wave, V wave, in a normal person, and now in mitral regurgitation, blood is coming not only from the pulmonary vein, blood is coming from the LV also. Huge amount of blood will be coming, and definitely excess blood has come. That is going to increase the pressure. So what happened? This pressure curve will become like this. V wave will be like this. V wave. So what we notice during systole, there will be prominent V wave in the LA pressure tracing by catheterization. This is one of the highlight of mitral regurgitation. Okay. So due to abnormal retrograde flow, there will be retrograde flow. There will be increase filling of the blood in the left atrium, and that will be getting very P wave, pressure wave will be very, very prominent, much more than what we see in a normal person. So in this slide and the last slide, only one keyword is that prominent V wave. Prominent V wave is the only keyword that you got to remember in LA pressure. Okay. So we are getting prominent V wave, and again saying in mitral stenosis, increased pressure occur in diastole, and in case of mitral regurgitation, the increased pressure occur in systole. The one line which I told you, but I want you to reinforce the statement, the LA pressure. So now you look into this same. Now you look into this V wave I'm talking about. Okay, this is a V wave, is a passive venous filling, and you can see this is wave is this is a millimeter of per mercury, and you can see the pressure here is almost as around 40 millimeter of mercury. The prominent V wave we are getting. Prominent V wave we are getting in what? In systole. And in diastole it is normal. Lovely finding for you. This indicate ventricle, left ventricle contraction, systole, ventricle systole. This is ventricle diastole. This is the diastolic pressure of the LA. This comes down to normal. This comes down to normal. So pressure rise only in systole, that you can see V wave. Lovely chart. I can remove the whole ink so that you can have a proper look at what I wanted to convey the message to you. Okay. So far, we talked about the blood all coming to left atrium and what the problem is. Now, additional thing, effect of afterload in mitral regurgitation. Okay. Again, a very, very important point. Basic concept. Basic concept. This is the heart, this is the aorta, and in MR, some blood goes here and some blood goes back here. That everybody knows. Now, blood is going to aorta and ultimately it will go to the small artery, ultimately it will go to arterioles. This blood will go to arterioles. And we know very well, our basic concepts are very clear. The arterioles are the primary site of peripheral resistance. Peripheral resistance is arteriole and peripheral resistance is the other name of afterload. Yes, everybody knows. But how can this affect the flow? Yes. Now, suppose there is intense peripheral vasoconstriction. And do I need to tell you more that peripheral resistance is directly proportional to 1 by R4. R is the radius of the arteriole. If the arteriole are constricting, vasoconstriction is there, peripheral resistance will increase, definitely, manifold it will increase. So definitely if the arteriole are constricted, that means less amount of blood will go to aorta because resistance is very high. More and more blood will go this way. But suppose you use any vasodilator, like ACEI. We all know ACI, they are vasodilator. So they will reduce the peripheral resistance, so this will help in the forward flow. That's the basic idea of using ACEI in both mitral regurgitation as well as aortic regurgitation also. Same principle applies. Right? So vasodilators are used in MR and AR. Idea is the peripheral resistance will get reduced. So now it will be much easier flow. More and more blood will be diverted to this side. Less amount of blood will go to left atria. Less amount of blood in LA will definitely going to reduce the basic pathophysiology of mitral regurgitation. So friends, this basic concept is the one. If you know this basic concept, your 90% of mitral regurgitation knowledge is complete. This is what they are going to ask you in any exam throughout the world. With this background, so we understood the importance of afterload, and we would like to use ACEI to reduce afterload so that more and more forward flow is there. With this background, now we talk about the clinical features. One again, most important clinical feature is easy fatigability, the commonest symptom of chronic MR. Again, reminding you, if they talk about MR means understood they are talking about chronic MR. And dyspnea, of course, is a commonest in acute. Acute MR is the most common symptom, but in chronic, it is a little late feature. Not a very early feature, little late feature. Palpitation occur when these patients are, because the LA size is enlarged, these patients are prone to atrial fibrillation. So once the atrial fibrillation develop, that lead to increase in the ventricular rate. Ventricular rate become very high, and that induces palpitation, means the ventricular rate is very, very high. Patient can even know and feel his own heartbeat, so-called palpitation. So easy fatigability, dyspnea and palpitation. Remember, palpitation again, repeating second time. Development of AF is a late feature. It's not a early feature. Signs. When you examine the patient, important signs. Displays hyperdynamic apex beat. We all know very well. Normally, the apex beat is in the fifth intercostal space in mid-clavicular line. In mid-clavicular line. Okay, let me show you a picture. Let us say this is the fifth intercostal space, and this is the apex beat. Fifth intercostal space in mid-clavicular line is there. Now in these patients, this is displaced down and out. Down and out. What's the reason? Again, basic concept. Heart. So, in systole, a large amount of blood which was supposed to go to this side, it goes to LA. LA volume has increased, we understood, that cause increase LA pressure, we understood. But what is the relevance of this point to apex beat dilated? Now in that next diastole, a larger amount of blood will come back to LV. More than what it's supposed to come in a normal. From a normal LA, double the amount of blood will come. So now during diastole, this left ventricle has to accommodate double amount of blood. One was the original, which is come from the normal LA, and the other one which is due to the blood which has gone to the regurgitation. Now the double amount of blood coming to that lead to LV dilatation, maybe LV hypertrophy also later on, and that will displace the apex beat down and late. Okay, it will be hyperdynamic. The hyperdynamic type of this apex beat, because heart is beating very fast. So we understood the displays and hyperdynamic apex beat. Soft S1, why? These two valves, the valves are not closing properly, the gap is there. When gap is there, there is no point. In mitral stenosis, S1 is loud, here it is reverse, it is S1 is soft. Loud P2, this indicates pulmonary arterial hypertension. The reason I told you why PAH occur, which is a late feature, because of all back pressure, pulmonary arterial hypertension occur, and that is loud P2. Now S3 is there. Why? Again, S3 is produced due to large amount of blood entering into the LV, large amount of blood, and that will produce third sound. We know very well the third sound is produced in the rapid filling phase of myocardium. Rapid filling phase of myocardium, and this occur in early diastole. Early diastole. So third sound is a very, very important finding on clinical examination in MR. Of course, chronic MR, no need to say. Pansystolic murmur at apex which radiate to axilla. So pansystolic murmur which radiates to axilla also. Again, go back to basic. So as the blood is leaking from LA to LV to LA, leaking, so it will produce a pansystolic murmur. That means the murmur will be there throughout the systole, and it will radiating to the axilla also. So friends, the signs are displaced apex beat, number 1, number 2 soft S1, number 3 is loud P2, number 4 is third sound, and number 5 is pansystolic murmur which radiate to axilla. Now we learned about intensity of murmur. We learned about murmur, that we are getting a pansystolic murmur. Let's talk about intensity of murmur. We know the basic concept that in case of mitral stenosis, longer the murmur, more severe was the murmur. Longer the murmur. Now let us see. Now what about here? Intensity of murmur does not correlate with the regurgitant volume. Okay? No. Why? Again, go back to basic. Go back to basic. Heart, and this is the mitral valve. Now it has dilated. So more and more space is there between the two valve leaflet. More the space, more blood will go. Suppose this is the aperture from blood has to go. This aperture, blood will go. Definitely bigger the size, bigger the entry gate, more and more blood will flow. So more blood will flow, but that doesn't mean that the intensity will be all the same. Rather, intensity may not be increased, or it may be two valves. This and this may have same intensity, but the amount of blood going in this is much more. So again, it has got no relation between the intensity of murmur and the severity of MR. Okay, rather it may be other way around, more and more bigger in size, so it may even result in reduced murmur intensity because bigger size is there. Now it doesn't have to put much effort to go into LA. So summary is, what is the summary of this particular slide? Intensity of murmur has no relation with severity. No relation with severity of the mitral regurgitation. Well, we have a case of mitral stenosis. We do the investigation. No need to say we'll do all the routine investigations, CBC, etc. But I'll focus what is needed for mitral regurgitation. ECG, yes. For every cardiac condition, ECG is the one basic investigation. It is just like what I say, every chest condition, the first basic investigation is chest X-ray or the ECG. We may get atrial fibrillation. We may get P-mitral. P-mitral, that is, this is the ECG paper. Normal P wave, height and width, both are less than 2.5 small square. If LA enlarges, the P wave height normal, but it's a wide P wave. Wide P wave means that it is more than 2.5 small square. Here you can see 1, 2, 3, 4. Wide P wave is P mitral, that indicates LA enlarge. And if suppose the only LA, if the RA is enlarged, then we get P pulmonale. P pulmonale indicate tall P wave. P pulmonale, this indicates right atrial enlargement. So P mitral and P pulmonale are the two things. Here we will be getting P mitral. Left ventricular hypertrophy, point to be noted, LVH was never a feature of pure MS. And it is the LVH which also contribute to displacement of apex B to left and the out. So friend, atrial fibrillation, P mitral and left ventricular hypertrophy that we can see in ECG. Chest X-ray, look into this chest X-ray. We are getting the enlarged appendages. And you are getting some opacity, and we can see that left angle is displaced, left main bronchus is displaced upward. This is a feature of LA enlarged, and this feature we saw in mitral stenosis also. So let me talk more detailed about LA chest X-ray in mitral regurgitation. LA and LV are dominant chamber in chronic MR. Definitely LA has enlarged, that we understood. Left ventricle hypertrophy has occurred, and it may be dilated also, that we understood. Late in the course of disease, LA may be massively enlarged and form the right border of the cardiac silhouette. The way, so now LA make the right border. Look into this. This is what we are seeing. This is what we are seeing. It is making the right border of the heart. This is being made by enlarge, and the later on, other than the straightening of the left border, it may even make the right border also. We can see the double shadow that we can see if LA enlarges, and this double shadow of right border is the classical feature of LA enlargement, and that is the feature that we saw in mitral stenosis also. Pulmonary venous congestion and interstitial edema and Curley-B lines can be seen, but they are much more commonly seen in mitral stenosis. There can be marked calcification of the mitral leaflet. Again, this can be seen in mitral stenosis also. And of course, when we talk about mitral valve calcification, that means the valve is totally non-viable. And of course, in acute MR, we get pulmonary congestion, and that can lead to acute pulmonary edema. Echocardiography is always one of the best early investigation for screening or to confirm the diagnosis also. So this, what all we can see in when we do echocardiography. LV function. How is the left ventricle function going on? Okay, we can get the left ventricle end diastolic and systolic volume. Definitely. How much volume is there, end systole and end diastole volumes. And we can even know the ejection fraction also. Left ventricle end systolic volume, left ventricle end diastolic volume, ejection fraction, all these we can get via echocardiography. We can also see leaflet structure and function. Definitely when we can see directly where the leaves they are deformed or they are calcified, we can see. We can see even the chordae tendineae by which papillary muscle is attached to the valve cusp, that we can see. We can also see annular calcification, whether there is a calcification the annula, which occurs in an elderly person, and that is an important cause of MR in elderly person. LA size and LV size, we can see, not only we can see the pressure, we can see the size also. And how much is the systolic function, we can see whether there is hypokinesia, etc. We can see all by echocardiography. Doppler study, we can know the width of the area of the color flow. Okay, how much is the jet in mitral regurgitation going into left atria? We can see how much blood is going. Duration and intensity of the continuous wave Doppler signal. How much is the flow of blood? One more thing, although we say in mitral regurgitation it's a pan-systolic murmur, and that we can see by continuity of the Doppler flow, but this is not 100% correct. In condition like mitral valve prolapse and in condition like papillary muscle dysfunction, it is not pan-systolic. It may be end systolic murmur. It will be systolic, but not pansystolic. So this duration, intensity of murmur, this you can differentiate by echocardiography. We can also see pulmonary venous contour. Blood flow is coming, okay, into the LA. We can very well appreciate how much blood, all we can see by echocardiography. Early peak mitral velocity, large number of blood is coming to the mitral valve in the systole, we can appreciate. And we can even quantification, how much blood is coming. Not only we can see the velocity of blood coming to the LA, we can also see how much blood is coming. We can even quantify also, okay, and this is what we call as regurgitation volume. But they write as RV. RV is the amount of blood in regurgitation that is coming from LV to LA. Okay, and of course we can measure the how much is the valve area, and finally we can measure the pulmonary artery pressure. We can measure that also. So by and large we have to do echocardiography, and that is essential. We have to look for the suitability for repair rather than replacement. If the valve is totally calcified, deformed, diffuse, whatever, then we have to replace the valve. But otherwise, the valve is pliable, then we like to repair also. What repair is to be done, that I'm going to discuss a little later on. But right now, echo has given a great amount of help to us to decide whether you go for valve replacement or you go for the valve repair. Okay. Now, so certain important point, etiology and severity of MR are the best seen by echocardiography. It's the best. OPD procedure, simple. You send the patient for echo, the report, you get report in half an hour, you come to know. But this is regarding echocardiography. But auscultatory finding, then S3 Gallup is the single best parameter by which you can see the patient has got severe mitral regurgitation. Point to be noted, third sound which is getting produced in the early diastole, which is due to sudden gush of the blood from LA to LV. We get third sound. Third sound is there, that means patient has got severe MR. Okay. So what are the parameters by which we assess severity? Enlarge LV. Larger the left ventricle size, more is the severe MR. Remember, we looked for left ventricle and diastolic volume by echocardiography, the point I mentioned to you. Third sound on auscultation, if you are getting severe. Flow mid-diastolic murmur, oh, something new. Basic. One thing I have told you, this is the mitral valve. I told you in diastole, large amount of blood comes. And that causes increase in left ventricle and diastolic volume. And here MR is there. MR means leakage of blood from LV to LA. But in diastole, large amount of blood is flowing back. There is no mitral stenosis, but still you may get a functional murmur of mitral stenosis. You may get functional murmur of mitral stenosis because of large amount of blood flowing from a non-stenotic valve. This again, you may get flow murmur. This is so-called flow murmur is there. A2, P2 interval wide, loud P2, regurgitant volume. I mentioned to you. By echocardiography, we can come to know how much blood is going from LV to LA, so-called regurgitant volume. And moreover, we can even come to know even how much regurgitant fraction is there. Means, again, suppose this is the end systolic volume, and systolic volume is 120 ml, let's presume. and maybe 50 ml goes here and 70 ml goes here. Let's just simple calculation, okay? Although not 120 ml goes out, only 80 ml goes out, 40 remain in the store, but just for easy calculation understanding, say 50 has gone, 70 has gone. That means the regurgitant volume is more than 50%. And regurgitant fraction is more than 50% and the volume is more than 60 ml. They all indicate severe mitral regurgitation. What complication can occur other than the pulmonary edema? They can lead to atrial fibrillation and infective endocarditis are the two major complications that can occur in this patient. Of course, pulmonary edema is a problem. So, when we will be treating a case of mitral regurgitation, let's learn the basic principle of treatment. Basic principle is first is to decongest. First is to decongest the lungs. Definitely, patient is having pulmonary edema, that's the first thing. Second, suppose the patient has got atrial fibrillation and this decongestion is done by the diuretics. Same thing, the first line treatment or even for mitral stenosis is diuretic. For AF, we give digoxin. This we do in mitral stenosis also. But what is the one more difference? Here we like to give vasodilator like ACEI. And this is not given in mitral stenosis. Not. So major difference between the two is vasodilators are given to reduce the peripheral resistance. And reduced peripheral resistance will help in the forward flow of blood, the point I mentioned to you. And this we don't do in mitral stenosis. Okay. So diuretic, digoxin, ACI, anticoagulation we can use. The patient has atrial fibrillation. This we did in mitral stenosis also. We will use anticoagulation when the history of embolism is there. We use the patient already has a metallic prosthetic valve. And if the patient has MS with MR, if the MR, MS is also there, we may like to go for anticoagulation and we use warfarin. Warfarin. Whenever we are using warfarin, we have to check the INR, prothrombin time INR, and we like to maintain between 2 to 3.4 is the range where we have to maintain INR if the patient is taking warfarin. Well, we do some surgical operation in some cases if deteriorating symptoms are there. You are giving the best medical therapy, but patient cannot tolerate, patient still having very low quality of life, then you can think about the surgical treatment. Aim is to repair or replace. Valve is there, if we can repair, good enough, much easier, less traumatic to the patient also. But if the total it is gone, there is no way out we can repair, then you have to go for replacement. So either the valve is repaired or the valve is replaced. Definitely, suppose you have a, well, everybody, suppose you have a air conditioner in your house and there is some problem. You call the mechanic, he come and repairs. Yeah, easy, less expensive, good. But suppose the mechanic come and see, oh, he say, oh, it's totally burnt, totally gone, nothing can be done. If nothing can be done, okay, you throw away this AC and you bring in new AC. So this is the repair and this is the replace. I think you got the answer. From day-to-day example, you could understood the meaning of repair and replace. If you can't repair, go for the replacement. Replacement, we can go for biological valves or we can go for metallic valve. Detail about these valves, when to use, how to use, I have given in great detail when I took the lecture on mitral stenosis. You must have seen that lecture. If somebody has not seen, please go and see the lecture. Everything I discuss in detail, so I don't want to repeat the same thing. But one thing is there, repair or replace. Now, we like to do mitral valve surgery. Surgical treatment will do severe symptomatic MR. Patient having NYHA, New York Heart Association class of dyspnea 234. We like to go for surgical intervention, and these are not being controlled by the medical therapy. Patient is totally asymptomatic, but ejection fraction is less than 50%, or LV and systolic diameter is more than 40 millimeter of mercury. These are the most important indication of going for the surgical treatment. We like to go for surgical treatment, but no doubt about it, this is the single best indication the patient has symptoms. Now, how we can repair? Repair. This is a normal valve. You can see this is closing. This is the mitral regurgitation. You can see the big gap is there. Okay, and now this is they are doing repair. Just see how what they are doing. And they are trying to shorten the gap. This is being by, okay. Look into this photo. If you can see it carefully, you are getting like this. And you are getting something like this. Look into this. Yeah. Look into this. Okay. They are trying to repair the mitral valve. What is this? Let me show you more picture. Oh, this is the one by which they are repairing, and this is known as mitral clip. This they do use to just repair the valve. Okay. Otherwise, if not possible, then go for valve replacement. So a quick recap of the last minute revision point. Functional dilatation seen in dilated cardiomyopathy causes, endal calcification in elderly, rheumatic heart disease, mitral valve collapse, connective tissue disorder like Marfan or Ehlers-Danlos syndrome, congenital, acute MR, infective endocarditis, papillary muscle dysfunction, chorditendony, and malfunctioning of the prosthetic valve. In acute MR, pulmonary edema. In chronic MR, it is easy fatigability, pan-systolic murmur. Diuretic to improvement, digoxin if heart failure or AF, ACEI, we anticoagulate if atrial fibrillation or history of embolic phenomena. Already patient has a prosthetic metallic valve or patient has mitral stenosis. Surgical, you can repair or you can replace. Repair we do by mitral clip. Mitral valve collapse. Again, basic anatomy. We are getting a normal valve closed. Yeah. Left atrium, left ventricle, everything normal. Here, this valve is getting prolapsed. Valve is getting prolapsed will lead to what? Leakage of the blood. Leakage of blood will happen. Okay, this is so-called mitral valve collapse. I can show you one more picture for better clarity. Okay, so this is a normal valve. During systole, the blood goes to the aorta. But in mitral valve prolapse, this valve has prolapse. Let me enlarge the picture. Yeah. This valve has prolapse and that creates a gap. So some blood goes to aorta and some goes to LA, and that's the basic pathophysiology of any mitral regurgitation. Let me give you example. Okay, this is the normal. Okay, this is a normal. Valves are closing. Valves are closing. Now, what happened? Prolapse is there, like this thing. Prolapse is there. Look, normal prolapse. When the valve get prolapse, it creates a gap. You try, all of you try. All the students should try. Leave your pen. Do like this. Yeah. Keep your finger straight. Yeah. Yeah. Now you keep your finger straight and right hand finger you bend it. You bend it, yeah. What you are finding? A gap is there. Automatically, definitely when you flex your fingers, it will be creating a gap. That is so-called mitral valve prolapse. Same thing, it has been depicted. Now you can appreciate these valves are like this, straight. Valves are like this. And now valves are like, one is there and this one is the flex, the way you have flexed your fingers, and that is definitely going to create a gap between the two valve cusps. This is the mitral valve prolapse. Okay. With this background of understanding, look into this is one more lovely picture. Look into this. This is the mitral valve, nicely closed. Here is the mitral valve. Just see, it is getting prolapse and you are getting a gap. You are getting a gap, same thing, but in a different way of presentation. With this background of lovely picture to make your concepts very clear, we move into mitral valve prolapse in more. It's the commonest valvular lesion in the world. This point is not known to 90%. Most common. And it is seen in around 7% of the young ladies. 7% young ladies. But fortunately, most of the time they are asymptomatic. And nothing worry about it. I have to give this word with a great emphasis. Because if I say 7% of the young ladies, that means there's one medical college, there are 100 students, 7% as per the books writing. 7 ladies are likely to have MVP. But medicos are the worst patient. For every small thing, we take it very seriously when we start rushing to the department of cardiology. Nothing worry about it. It's a normal finding. No worry at all unless some problem is there. But don't worry. This is out of the context of my lecture, but I'm telling to so reassure, don't worry. If any one of the one who's listening to me has problem, don't worry at all. Reassurance is the best, okay? So, well, as I discussed, I will show you picture. In MVP, there is systolic displacement of belly of mitral leaflet. You see, in systole, the belly of, this happen in systole. During systole, belly of mitral leaflet get prolapsed into the left atrium. At least 2 millimeters superior to the plane of the mitral annulus. Point to be noted. It is even going 2 millimeter above the annulus. That's why a gap will be created. And remember, he's saying systolic displacement, not in diastole. That's why we will be expecting some systolic murmur in this case. What is that? I'm going to discuss later on. And one more thing, prolapse can be one or both leaflets, not essential only one leaflet will prolapse. Look again, same diagram, one leaflet, two leaflet. The two leaflet are prolapsing, definitely gap will be much wider. Right? Point to be noted. causes. It can be familial autosomal dominant, very, very important condition. Okay, dominant. Or otherwise it may occur with ASD, it may occur with PDA, it may occur in cardiomyopathies, Turner, Marfan. This is the single most important. And second important is WPW syndrome. So in the whole list, 1, 2 and 3, don't forget these 3, very, very important. What are the symptoms by which patient is going to come to you? Majority of time, no symptom at all. I told you, maybe incidentally they are picked up. The patient was getting some health checkup. During health checkup, they did the echocardiography and they found it. Okay, then it's a duty of the one who has done the echocardiography to reassure. Nothing worry about it as long as there is no symptom. Otherwise, atypical pain chest can occur, palpitation and embolic phenomena. This is really a matter of concern. Okay, but it's very rare to happen, but embolic phenomena can occur. Now I give you a list of the condition, extra edge. What are the other conditions where we can have embolic phenomena in cardiology? So in cardiology, these embolic phenomena occur in mitral stenosis, atrial fibrillation, endocarditis, mitral valve prolapse, acute MI, okay, metallic prosthetic valve, point to be noted, it is metallic prosthetic valve, it is not the prosthetic valve, because biological valves, they don't have embolic phenomena, the clinical applied. That's why warfarin we don't use in biological valves. But in metallic prosthetic valve, the embolic phenomena is very common. So we use warfarin, and as I told you, we try to maintain INR between 2 to 3.4 when we are using 3.4, when we are using warfarin in metallic prosthetic valve. Well, now come the gold medal question. We have a term called paradoxical embolism. The question is, in which condition, a question only for the student, write down the answer in your copy. Now, in which condition you get a paradoxical embolism, and what is the base, what do you mean by paradoxical embolism? Or simply write down in which condition you get paradoxical embolism. Well, the answer to the question is tetralogy of Fallot. Here we get paradoxical embolism. What is this? Patient may develop a clot in the veins. From the veins, blood come to the heart. It come to right heart, it come to right atria, then it come to right ventricle. But from right ventricle, we know there is overriding of aorta occurring in tetralogy of Fallot. It goes into systemic circulation. So a venous clot goes to systemic circulation as an embolic phenomena. This is so-called paradoxical embolism. Okay. I hope this additional thing that you got regarding embolism phenomena. With this background, we come back. Signs. What are the signs you get in? You get non-ejection mid or late systolic click. Very, very important. This is S1, this is S2, and you get a click just before the second sound, as you can see. See, click is there. This is due to opening of the valve. Okay, click, and you are getting late systolic murmur. Point to be noted that we are getting mid or late systolic click, and similarly we are getting murmur systolic, although it is a systolic murmur. Okay, it's not a pan systolic murmur, it is a late systolic murmur. It is a late systolic murmur. But in the very advanced stages, it may be pan systolic, but by and large, for all exam point of view, it is a late systolic murmur. But nobody going to ask you this. What they asked you, the single most important line in the entire MVP, the intensity of this murmur increase on standing and Valsalva. On standing and Valsalva, the intensity of murmur increases. There are only two murmurs which have this quality. One is MVP, other is HOCM or hypertrophic obstructive cardiomyopathy. The only two murmur which increase on standing and Valsalva maneuver. Okay. Now let us see why this happened. This is the most common cause of chronic MR, especially in the developed country like Europe or in America or USA. Well, in developing country or subcontinent country, rheumatic heart disease is also a common cause. But not to forget, MVP is the most common valvular lesion in the world. And especially in this developed country where RHD is not so common, but MVP is common. In fact, why this happened? This is due to myxomatous degeneration of the mitral valve, leaflet and chordae. This, if you get myxomatous degeneration of valve, 100% you are dealing with mitral valve collapse. But what is the idea? And this is the one which produces mid-systolic click and mid-systolic murmur that we understood. But what is this? What is the biochemistry of myxomatous degeneration? This is not known to 99%. It's a very commonly asked question in biochemistry. Basic. So let's learn about basic biochemistry of myxomatous degeneration. Well, there is buildup of glycosaminoglycan. Glycosaminoglycan accumulate in the leaflet of the mitral valve. And what is this? What is the chemical formula? It is dermatan sulfate. So you can say dermatan sulfate get accumulated in the valve leaflet. Okay. So you have to remember only one keyword is dermatan sulfate. Okay. And it is this molecule which get deposited in the valve, and that lead to fibrosis. Okay. Normally, what is the role in a normal person? Well, if suppose an injury occurs to one person, that ulcer heals and it gets fibrosed, done by dermatan. It helps in the wound healing and it has some role in coagulation also. It means in a normal person, it is a help in having the wound healing and fibrosis. But when it get abnormally accumulated in the mitral leaflet, mitral valve, so not only it destroys the mitral leaflet, it also destroys the chordae tendineae. Okay. Now these structure ultimately they become redundant. They become useless. It destroys, and ultimately that lead to weak valve cuffs, and then weakness will always like to prolapse. So what in nutshell I can say, it weakens the valve from inside. So that's why the valve become weak inside. That's why now they are not able to maintain the rigidity. They try to collapse by systolic, but this happen in systole. Okay. So ultimately, it cause liver dysfunction due to MR, and MR lead to LA dilatation. This is what I discussed already, so no need to repeat. Just to examine you MR and that lead to same what happened in any case of mitral regurgitation. LA will get enlarged. Is not due to MVP, is due to regurgitation of blood from LV to LA is the problem. What complication can occur? Embolic phenomena, arrhythmias, and sudden death. This one condition which can lead to sudden death also. Let me give you extra knowledge. What are the cardiac condition where we can have, a patient can have a sudden death? Sudden death can occur in acute MI. It can occur in HOCM. It can occur in aortic stenosis. It can occur in mitral valve collapse. There are some of the important conditions where acute MI can occur, or acute sudden death can occur. But in the exam, when they talk about sudden death, the most young man, this is the one thing which is most oftenly asked. Sudden death in a young man, they talk, 99% they are dealing with HOCM. Remember, sudden death in young person. MI, of course, this may occur in younger patient, but slightly it occurs in around 40s and 50. But when they talk about sudden death in 20s, think about HOCM. So, same story, you can see the leakage. What test we are doing? Electrocardiography for any valvular heart disease or any congenital heart disease. The first screening test is always echocardiography. Of course, you will do ECG first, but ECG is not giving, ECG will just change you the electrical changes. But if you really want to know the cause of the problem, echocardiography is the usual best screening test for any congenital heart disease or any valvular heart disease. Of course, later on, if needed, we can go for cath, but in MVP, catheterization studies are usually not needed. Okay, but echo is good enough to give you the answer. Treatment, normally we don't give any treatment unless there is some specific problem. We give beta blocker if the patient has palpitation or pain chest, and we can give endocarditis prophylaxis is if only MVP is there, the endocarditis prophylaxis is not needed. But if there is, with the regurgitation, remember in the initial stages, patient may not have regurgitation, there may be only prolapse will be there. Then endocarditis is not there, but MR is there, then we have to give. But still, MVP is one condition where endocarditis is usually uncommon as compared to other conditions like MS, MR. Okay. A quick recap of the last minute revision point. It is an autosomal dominant condition. It may be seen in Turner syndrome. It may be seen in Marfan, osteogenesis imperfecta. The clinical feature is symptomatic, may be atypical pain chest, palpitation, embolic phenomena, non-ejection systolic click, mid-systolic click, late systolic murmur, and intensity of murmur increase on standing and Valsalva. There are only two conditions where this happens. One is HOCM, other is MVP. Complications, sudden death can occur, embolic phenomena can occur, endocarditis can occur but not common. Treatment, beta blocker. Thank you very much. God bless all of you.